So next is the sleeve gastrectomy. This is probably the newest procedure on the scene right now between band and bypass. It's been around for more than 10 years. This was initially done as a first stage procedure for people to have a bypass or a duodenal switch operation, but then in the last really 5-6 years it's been done as a primary operation, meaning that it was intended to be the only operation for folks. As you can see here, it really is fairly simple in concept. It doesn't mean it's easy to do, but it is a removal of about 3/4 to 9/10 of the stomach. We leave a tubular stomach or a sleeve behind. I tell people the shorthand term is, we're turning this football-shaped stomach into a banana-shaped stomach. That's a little bit of an oversimplification, but that's the basics of what it's about. It is truly irreversible, though, because this part of your stomach comes out of you and is gone. So it is a removal, the same as if we remove your gallbladder or remove part of your colon or remove your uterus for hysterectomy. It is not something we can put back in. So I do think that irreversibility intimidates a few people. You still do have lots of stomach tissue left, though. It does give more than just a simple restrictive effect. Originally we thought it was more like the band, where you just have this smaller stomach and it doesn't give any hormone changes or much in the way of hormone changes. But that's being in the process of more evaluation, shows that the ghrelin, the hunger hormone that we see change with the gastric bypass, also changes in the sleeve. Not exactly in the same way, but very similar in terms of the outcome for most people. It is less invasive than a gastric bypass, as you'll see, the Roux-en-Y gastric bypass, RYGB, because we don't have to do any work on the small bowel. It's only on the upper abdomen in the stomach. We have only a few 5-year studies, and they're fairly small, and they're done with some older techniques, and that definitely shows some failures of weight loss early and some regain of weight with more people than we would expect to see with a gastric bypass in the long term, in the 2 to 5 year term. Now, some of those procedures have been slightly modified, and we make slightly smaller sleeves than they were probably making 5 and 6 years ago, but I do think it has a higher risk than a gastric bypass of having late weight regain and potentially early failure where the patient just doesn't get the satisfaction, the food satiety that we see. It's not quite as strong a tool. I think, though, for a lot of people it is a good, it seems to be the sweet spot that people are looking for, where they give that a try, and if it fails you early or if it fails you late, that you can take a step up to a gastric bypass or a duodenal switch later. Not that we ever intend to operate on somebody necessarily twice unless it's for super high risk, a planned 2-stage procedure. But that is going to be a reality for some folks. It is truly irreversible, like I already said. It can be fairly easily modified, however, to a gastric bypass or to a duodenal switch operation, either for reflux, and that's probably my main concern here, is that some people have described increased reflux in a few individuals. Most people's reflux gets better as they lose weight, but if you have reflux that worsens, a sleeve can probably be changed to a bypass and give much better reflux control. So it's something to be aware of. That is an uncertainty. I don't want people to think, oh, I'm going to get a sleeve and I'll never have a bypass, because there are going to be some people who need to have a bypass from a sleeve. So I don't want people to feel surprised or that they were promised, that the sleeve was going to do it for them and they wouldn't have to have a bypass. Also, if you have a leak from a sleeve, many of the described rescue procedures from that is to convert it to a bypass, because sometimes that stomach, if it's not healthy, that middle part of that tubular stomach needs to be removed. Currently the sleeve, I use the word favored here. A lot of surgeons like this procedure because it is simpler, it is faster, it has a little less worry for us than a gastric bypass, and it seems to have a lot of patients who are very happy. Where we will be 5 years from now or 10 years from now, it's very hard to say. We were very happy with the band when it was first out, and I think most of us as surgeons feel like we were a little over enthusiastic about the band. As I said, I still really do think the band is a great tool, and I think that 5 years from now, 10 years from now, I will still think the sleeve is a great tool as well. But I'm just a little more cautious about maybe over-promising that the sleeve is just what the doctor ordered. But I will tell you, it is a very good tool, and we are very happy to have it in our armamentarium.